I'm Dr. Rebecca Shakir, a clinical oncology registrar and doctoral research student at the University of Oxford. Thank you for the opportunity to present our research, which is a qualitative study investigating the experiences of patients and clinicians in the UK in making decisions about radiotherapy used to treat Hodgkin lymphoma. Hodgkin lymphoma is a cancer of the lymphatic system. Treatment is with chemotherapy, which can be followed by radiotherapy. Radiotherapy increases the chance of cure, but also increases the risk of cardiovascular disease and subsequent different cancers. We do have guidelines that broadly indicate which patients should be treated with radiotherapy, but the balance of benefit and risk varies between individuals based on factors such as their age and sex and the distribution of lymph nodes affected by Hodgkin lymphoma, demonstrated here on a PET-CT scan. Quantifying and incorporating these factors into clinical decision-making is difficult, and little is understood about how decisions about radiotherapy are made in current clinical practice, and patients' preferences for involvement in this decision-making. The aim of this study was to explore patients' and clinicians' experience of the radiotherapy decision-making process, and to better understand how patients' information needs and preferences are taken into account for making shared decisions. We interviewed 15 people treated for Hodgkin lymphoma within the last 5 years, and 12 clinicians who specialised in the treatment of Hodgkin lymphoma. Due to the COVID-19 pandemic, all interviews took place over Microsoft Teams. In the interviews, we explored how optimal treatment is decided on, the role of patients and clinicians in these decisions, and the concept of shared decision-making in this context. We applied maximal variation sampling and coded the transcripts using NVivo software, and used Brown and Clark's thematic analysis to identify key themes from the interview. We identified 4 themes from our interviews. The first was patient involvement in decisions. The second, individual factors influencing decisions. Thirdly, the responsibility for decisions. And finally, shared decision-making in the context of Hodgkin lymphoma. And I'll now discuss each of these themes in turn. The first theme described how patients were involved in the decisions about radiotherapy. Most patients reported that their treatment plan was presented as a conclusion, rather than there being a discussion of options. Patients knew that they didn't have to have a treatment that was offered, but as this 36-year-old lady said, it wasn't really a discussion in as much. Obviously I've got a choice whether I choose to have it or not, but there wasn't like, all right, there's 2 treatment options on offer for you. Patients' perceived lack of choice was exacerbated by being overwhelmed by the amount of information given to them about their diagnosis and treatment options, and the feeling that they were in a life-threatening situation with no real choice, as the only choice they felt was between treatment and probable survival, or no treatment which would probably result in their death. The second theme was the individual factors that clinicians and patients felt fed into the decision-making process. Primarily, these were which parts of the body were affected by lymphoma, and the sex and age of the patient. There were other personal factors, such as the patient's medical history, lifestyle factors, for example smoking, type of job, or having a friend or relative who'd been treated for cancer, that influenced the decision. None of these individual factors were deciders in their own right, but they all played a role when patients and clinicians came to decisions about radiotherapy. Patients' decision-making was driven by a wish to avoid relapse of their Hodgkin lymphoma, whereas clinicians were driven by wanting to avoid the perceived risks of radiotherapy, and this was despite acknowledging that relapse was their patients' primary concern in the majority of cases. The third theme was about who held responsibility for decisions about radiotherapy. Clinicians' views are summarised well by this quote from a medical oncologist. I think that we have to be careful as professionals to make sure that they don't feel the responsibility for taking decisions is entirely on them. Clinicians felt that it was a huge burden to ask patients to make the decision about radiotherapy, and the majority of patients echoed this view. One patient, who was in the minority, felt that the decision about radiotherapy was shared, and he had a different view about this responsibility for decisions. He felt he wanted to be involved in the decision, so that if something happened, and by that he referred to developing side effects from radiotherapy, he knew that he'd made the choice to have the radiotherapy in the first place. Linked to this decision responsibility was a discussion of decision roles. Patients explained that their preference was for clinicians to lead decisions, and that's because of their expertise. They described that having clinicians make decisions for them removed some of the anxiety and pressure around their treatment. Most patients wanted clinicians to tell them what was the best treatment, and clinicians in the whole were happy to recommend one option to patients. Clinicians reported that patients often asked them what they would do if they were the patient, and all were happy to answer questions if posed. Overall, patients expressed a preference for clinicians to guide decisions, and they were reassured that treatment plans were being agreed by a multidisciplinary team rather than a single clinician. The final theme encompassed shared decision-making. Most patients hadn't heard the term shared decision-making, but understood the general concept of involving patients in decisions about their treatment. Clinicians felt that shared decision-making was about involving patients in discussions, but not giving them the burden of making the decision. They felt shared decision-making was achieved by tailoring the information they gave to the individual patient, building a partnership, respecting the patient's autonomy, and individualizing treatment to the patient's circumstances. Most describe the process of shared decision-making as setting out the treatment options, being guided by a patient's response to those, giving an option as to the best treatment option for that patient, allowing the patient to consider alternative options, and then coming to a joint decision about the right treatment option for that patient. One haematologist described shared decision-making in this way: "To my mind, shared decision-making is not asking someone to take an equal part in making complicated decisions. It's about making sure that the patient's interests and needs are represented in that decision-making process, and it's not, you don't just make a decision without any thought to the patient." This figure describes the decision-making process about radiotherapy in current clinical practice in the context of Hodgkin lymphoma, as described to me by the patients and clinicians I interviewed. Decisions about radiotherapy lay mostly with the clinicians, as the experts in potentially life-threatening situations. They made the decision using their own medical knowledge and clinical guidelines, as well as being influenced by their own experiences and biases about radiotherapy. They integrated information from the patient into this decision, particularly their age, sex, and distribution of lymphoma, and their medical history, but also the attitude of the patient towards radiotherapy, and the patient's focus in terms of the short-term benefits of radiotherapy versus the long-term risks. Clinicians then made a treatment recommendation, which patients either did or did not consent to come to a final treatment plan. Whilst the patients interviewed were happy with the clinicians taking the lead in decision-making, there are areas we could work on to improve patients' involvement and enhance the decision-making process. One would be to be more explicit in explaining how and why decisions are made, and better explore how much patients want to be involved in those decisions. The second would be to improve the general public's understanding of radiotherapy, to reduce the unknowns that people face when radiotherapy is raised as a treatment option. The last would be to develop a decision aid that gave estimates of the risks of radiotherapy for an individual patient, and that's what my research group is working towards developing. I would like to thank the patients and clinicians for giving up their time to be interviewed for this study. This project was co-designed with a project advisory group made up of people from the Oxford Blood Group who have lived experience of being treated for lymphoma, and their insight was crucial to the success of this study. I'd also like to thank the National Institute for Health and Care Research for funding my research. Thank you for listening, and if you have any comments or questions, please contact me on my email here. Thank you.